And Miss Anna, you can go.
Okay. Are you guys able to see the real DX?
Yes.
Okay, good.
Okay.
Uh-oh.
How long has that been there? It's happened about 3 hours ago. Has he been able to pee since it happened? No. No? Okay. So the urologist is going to go ahead and try to reduce it. It makes it hard because you're now. Alright, we're going to be squeezing. This is going to take a while.
Okay. Am I back online with you guys?
Yes.
Okay. Sorry, that was a little traumatic. Okay. So we have a 10-month-old baby that came in with his mom with pretty acute 3-hour of a history, acute onset of the redness and the swelling that you guys saw at the distal end of his penis. No reported trauma. Mom came in with the baby crying, as you could see, with a lot of distress. No significant past medical history for this child. Born healthy, otherwise healthy, no daily medications on file, lives with his parents. Objectively, in clinic, all of his vitals were elevated, clearly because he was in quite a bit of distress. And so fairly clear diagnosis. The only differential that we would consider is phimosis and paraphimosis. And so phimosis would be certainly the foreskin that is unable to retract. And so there's two different kinds. There's the physiological phimosis, and then there's the pathologic phimosis. To differentiate between the two, the physiologic is sort of a normal variability that we see, and that's usually where the foreskin isn't retracting, but it's asymptomatic, and it usually self-resolves by the time of puberty. Pathologic phimosis would be more symptomatic, associated with pain, associated with painful urination. And this is the type of phimosis where you had a previously retracting foreskin that all of a sudden is not able to retract. And so you do see that in older children. And so with this child, you kind of see the opposite. You see the foreskin kind of stuck behind the sulcus there, and very, very painful. You see the swelling, the acute onset, the redness. And if you see this in office, this is an urgent referral. And so this child, as you can see, that was a child that was brought into the hospital setting. The risk here is, number one, the intervention would be to try and manually retract or manually bring that foreskin back forward. And that would require some pain medication and pretty good access to surgical intervention if, for instance, you were unable to fully be able to reduce the foreskin. Some risks there: you could get necrosis if not surgically intervened on time. And then some good education for mom would be to prevent future occurrences, making sure that after urination, especially for an uncircumcised child, making sure that they bring the foreskin And these children, and this was a part that maybe Dr. Whitehead, you can give me some clarification on. It also said education about no circumcision for these children, and I was kind of curious about I would think that circumcision might help if this wasn't a reoccurring problem.
Well, years ago, that was the big thing, is we would always try to say, do circumcision, but that's really a personal decision, and it's really a family decision. So they try to work around the circumcision part. I know that a lot of people who are not circumcised, as they get to be older adults, they tend to have a little bit of problem as well. They don't want you to push circumcision because sometimes it's a religious reason why they're not circumcised. It's a cultural reason why they're not circumcised. They found that it's painful to the child. So I think it's a personal factor, and that's the reason that they say that it's not a reason to have to do circumcision if you continue to do the things that the patient education and patient teaching is supposed to prevent you from having to do that.
Okay. So that's all.
Yep. Okay, good job. So what would you do if it was just phimosis?
If it was just phimosis, I think the original, you do a trial of a steroid cream to try and get that to reduce.
Good job. Is anybody having questions for Anna? No questions. Anybody else have the same video? No. Okay. All right. Well, we'll go ahead and let Amber, since you're right beside Anna, we'll let you go next. Click on your other tab, Anna. The Real Diagnosis tab. Can you hear me? No. All right. I'm sorry, not Anna, Amber. Amber, can you hear me? Did we lose her? Adrienne, do you want to go ahead and try to screen share and you do yours? She'll probably come back in a minute. I'll have her muted just in case.
Okay, can you guys see my video?
Yes, ma'am.
Okay, here we go.
Okay, so can you tell me how you're feeling right now? Bad? What hurts? Your tummy? When did it start hurting?
When I wasn't eating lunch at my school.
Yeah. Can you point to where it hurts the worst? Right there. Use one finger and show me. Right there? Okay. Grandma, can you tell us what medical issues he has?
Braden has delta granule storage pool deficiency, which is a platelet disorder, and he also has inflammatory linear varicose epidermal nevus syndrome.
Okay.
It's a genetics disorder.
Okay. And he started having pain today?
He's had pain for a couple of days.
Okay.
Yes.
Worse today?
Yes.
Any fevers?
High fever, 103.
Okay. And then has he thrown up at all?
Yes.
Okay.
He's thrown up yesterday and today.
Okay. And he's pointing right here where his belly hurts.
Correct.
Okay. Brayden, I'm going to push on your belly really quickly, okay? Does it hurt right here?
Yeah.
It does. When I press there, where does it hurt? Point to where it hurts. Kind of right there? Okay. When I press there, where does it hurt? Kind of right there too? Okay. How about when I press right here? Right there? Okay. And he's also had some pain medicine before we did this exam.
Thank you.
Okay. So this guy, he is a 7-year-old male, had the history of abdominal pain and fever, also had nausea and vomiting. He does have some interesting medical history. The grandmother spit it off, right off the tip of her tongue. The granule delta storage pool deficiency is a platelet deficiency. And then the inflammatory linear varicose epidermal nevus syndrome is birthmarks from the overgrowth of the epidermis. It's also noted in the text that he has autism and a developmental delay, although he seems pretty high functioning from the short interview. My top 3 differentials would be constipation, appendicitis, and gastroenteritis. The most favorable one, of course, is appendicitis with the high fever of 102, 103, I think it said. For the workup, you would do the CBC, CMP, and urinalysis. Initial imaging for appendicitis would be an ultrasound, which it looks like on this case they did a bedside ultrasound and then went ahead and ordered the CT abdomen pelvis with contrast. Maybe the ultrasound wasn't very definitive. And he actually was diagnosed with appendicitis. The treatment, of course, is NPO, IV fluids with pain medicine, nausea medicine, antibiotics, and a surgical consult.
Okay. Does anybody have any questions for Adrian? Did anyone else do this case? Okay. So tell me, if you see this patient in your practice, what exactly are you going to do with this patient? Tell me how you would handle just starting your workup. Tell me what you would do.
I mean, if I was highly suspicious of an appendicitis, or especially like a ruptured appendicitis, I would consider that an emergency and refer it to the ER. That way you get all your labs and imaging back stat.
Okay.
You get them a surgery.
Would anybody else do anything else? We got to speak up, guys. Anybody?
I guess it depends on what you have in your practice, but if I could do some imaging just to get a better idea of whether or not, it is appendicitis before I send them on.
Okay. Anybody else have any ideas what they could do?
Would you go ahead and start your lab work, your CBCs, CMP, that sort of thing? And I guess if you could you start, is it necessary to start like IV fluids for him?
No, not really. He didn't look like dehydrated like you would have to have an IV. So we got to pull ourselves from being nurses to being nurse practitioners. Okay. So the big thing is trying to keep people out of the emergency room. You don't want to send kids to the emergency room if you don't have to. Now, if you're in a rural area, you don't have a surgeon that you can call, or you can't get outside imaging done, that's another thing. But if you're in an area where most people you can get a CBC. A lot of people have CBC right in the office. You can check his CBC. Now, will a CBC always be elevated if he has appendicitis?
No.
No, it will not. So that will help. You can also do a urine in your office to see if he's got a urinary tract infection, right? You could do that. Would you need a CMP at this point? Probably not. You probably don't need that. I mean, it's not going to show you a whole lot, just your electrolytes, kidney function. That's probably not necessary. They may want it done before he has surgery, but it's not an emergent thing to rule in appendicitis. The other thing is, what about an ultrasound? Could we do an ultrasound?
That's what I was thinking.
Yeah, it just depends on what the clinic's capable of.
But you can still order an ultrasound outpatient. You don't have to send them through the emergency room to do an ultrasound. You know, because if they go through the emergency room, chances are they're going to get a CT scan. Okay?
Yeah.
And do you want them to have a CT scan if you don't have to have one? No. It's a radiation problem. So what I usually try to do is there's a couple ways of handling this. You can do a CBC, call the surgeon, ask if they'll admit them for observation and do an ultrasound while they're in obs. That's one thing you can do. You can do a CBC and an ultrasound, get those results back. If they're both negative, but the kid's still not feeling well, you can admit them for observation. You can send them to the emergency room. Chances are they're going to get a CT scan, and that would rule in appendicitis. So a lot of times with kids, they have constipation too, so you can't always see the appendix on an ultrasound. If they're heavy children, you can't see hardly any time. Okay, so CBC is normal, ultrasound's normal. Then what are you going to do? So you've got this kid home waiting with belly pain. CBC's normal, ultrasound's normal. What would be your next step? You got all that back. They had all that done, and then they called you and said everything was normal. What are you going to do now? Anybody?
I might be wrong, but I probably would just educate the parent on any acute symptoms, and if they have any of those warning signs, then I would direct them to go to the emergency room.
If they're holding fluids down and they're doing okay, I usually just if I've got a kid that I highly suspect appendicitis with, this is exactly what I do. I'll order an ultrasound and a CBC. If both of those come back okay, then I call the surgeon and I said, you know, I've got this kiddo here. I give him the whole spiel. I give him the physical exam. His ultrasound can't really visualize the appendix. The CBC is normal, but I really feel like that he's probably got a early onset appendicitis. Can you admit him for observation and just watch him? Sure, we'll admit him. And they do. They do. And then they can decide whether they feel like that he's bad enough. They can they can do serial CBCs on him in the hospital, and you've averted the emergency room, you've averted a CT scan unless it's absolutely necessary. Okay? So I do things like that. Now, if you don't have a surgeon that you can call to do that, then you have to send it to the emergency room, and you know, and you just really can't leave it hanging out there waiting on the appendix to rupture. But if you suspect, you've done your assessment, you suspect it's appendicitis, you've done the two things in the office, and they've come back that you either can't visualize it and it's negative, then you pretty much need to call a specialist at this point to move on to something else, okay? Make sense? Anybody have any questions?
I was just going to say, I learned a lot from that because I really was at a loss when you were asking. I was like, I really don't know what to do.
And that's the thing, and that's what this is all about. That's what these lectures are about, is for us to take these cases and work through them. It's okay if you don't know, because you shouldn't know. You're learning. We're in this learning phase. But if we see the cases and then we don't know what we're going to do with them, so what you do when you get out and you're practicing, you're going to be with a preceptor, and she's going to help guide you. What I want you to know is how to recognize it. I want you to know, this is my differential. It could be mesenteric adenitis. Does anybody know what that is? Yeah?
Yes.
Okay.
It's a viral inflammation.
It is, of the mesenteric tissue. So what happens is it gets inflamed, and it's like the old-fashioned stomach flu. They get sick, their belly hurts, you think it's appendicitis. They can keep it for up to 3 weeks. It's diagnosed typically because we think they have a appendicitis. We do a CT scan on them because everything else has been negative. They're not getting any better. They get a CT scan and it shows they have mesenteric adenitis. So with that, that's one thing that kind of waxes and wanes, and it acts a lot like appendicitis, but it's just a viral illness. And so that's one of the things in your differential when you have someone who's got that McBurney's points tender and right lower quadrant pain that's kind of waxing and waning like it does. That's one of your differentials. Okay. The other thing, it would be constipation, right? Wouldn't that be your 3 differentials with this kid? So you got 3. Constipation's minor. Mesenteric adenitis, that's not major, but it's painful, and they're sick for a while with it. They can get dehydrated. And then the bad one is appendicitis. Well, the first thing we jump on is appendicitis, correct? That's the first thing because that's the most important thing we have to rule out. Okay? But we have to keep those differentials in mind. So if you get an ultrasound and it shows a bunch of stool on the ultrasound, he has a history of constipation, then you've got possibly it's just constipation. But can you still rule out appendicitis? Not yet. You have to kind of figure it out. And sometimes it takes a while when you're doing it on an outpatient basis. And as nurses, and we want everything done right now, especially if you've ever worked in the emergency room or critical care. You want it done. Let's order everything under the sun, and let's do it right now, and it has to be finished. And so we have to learn to kind of work around that in the office. Everything's not an emergency in the office. And what we have to do is try to do it in that step sequence process. And then if you come out to the end of your rope and you've checked the things you can do in the office and those are negative, then that's got a case that you can contact a specialist at this point. And you contact your specialist and you're going to say, I need you to admit them. Or can you admit them? Will you admit them? And they usually will. They don't want to miss appendicitis either. But appendicitis is one of the most missed. It's one of the most missed diagnoses there is, because the CBC the white blood count don't always elevate quickly, and they have nausea and vomiting just like a viral illness. Okay. All right, that's a good case. Okay, so Amber, do you want to try yours again? Okay. Are you having trouble? I can't hear you at all. Are you muted? Are you there, Amber? If it didn't pick up your voice when you log back in, you may have to log out and log back in because we can't hear you at all. Okay, she logged out. All right, let's go to, who wants to go next? Kristen, let's let you go next.
All right. Okay. Can you all see it?
2 weeks of projectile vomiting. Yes.
Okay, great.
Okay, this is a 6-week-old baby who's admitted for a history of 2 weeks of vomiting and getting worse. Mom describes it as being projectile. And if you notice right in here, there's a slight little mass. You can see it's about the size of an olive. And you can see the baby will have visible peristalsis when she feeds. Mother describes projectile vomiting. But you come right in here, and it's noticeable, more noticeable when she goes through having a peristaltic waves. The heart exam is normal, chest exam is normal. The baby's starting to lose a little bit of weight at this point. Otherwise, it was a normal, spontaneous vaginal delivery, no other complications. The baby's not running a fever, and the rest of the exam is normal. But you can just see right this little mass in here will come and go. It's like the size of an olive. It's right here. You can actually feel that. It comes and goes. especially after if the baby eats, they can kind of see it sticking out a little bit easier. So, right in that area. Most likely diagnosis is going to be pyloric stenosis, and we're going to get an ultrasound done of that. And assuming that that's the diagnosis, maybe we can have the surgery, get a Z-plasty done. When the peristalsis happens, it's a little more visible.
All right. Are you all still with me?
Yes.
Okay, great. So I kind of just did mine in this format that we've used in past classes just to formulate my thoughts. So I expanded on the story a little bit because I think this is a pretty clear-cut case of pyloric stenosis. It's kind of got the classic signs, but I did a little HPI, infant in fair state of health, with history of 2 weeks of vomiting that is getting worse, more frequent and forceful, and that's very typical of pyloric stenosis. Mother describes the vomiting as projectile with no cough or wheezing. Patient is bottle fed, and mother changed from a dairy to soy-based formula 1 week ago with no improvement. The baby is having regular bowel movements, small, soft, and formed, with 5 to 6 wet diapers per day. The baby's lost 0.2 kgs with no feeding difficulties, no poor appetite, sleep disturbances, or lethargy. So our active medical problems for this baby is projectile vomiting and weight loss. To make my case more perfect, I added that this family has a history of pyloric stenosis in an older male sibling, because that's a risk factor for pyloric stenosis, is a especially in a sibling. To rule out my other differential diagnoses, which would be GER, I added that there was no gagging, hiccuping, or thumb sucking, which is typical of gastroesophageal reflux. And then going down here, I noted just that the mucous membranes were dry, that the infant was alert but not restless or agitated, which can be seen in other differentials, which I'll come to here in a second. And then the really characteristic thing for pyloric stenosis is a palpable olive-sized mass in the right upper quadrant, more easily seen with peristalsis when feeding, with normal bowel sounds. The olive-sized mass has a positive predictive value of 99.3%. So if you see this, you've pretty much got a diagnosis. And then I just put a definition of what that is, which is a thickening of the pylorus section of the stomach, which prevents gastric outflow, and usually occurs with infants between 2 and 8 weeks of age, and is 5 times more common in males. And this is a little male baby. Treatment for this disorder would be referral for a laparoscopic pyloromyotomy, as well as fluid and nutrition replacement. And both the book and Dynamed recommended that this baby be put on a normal saline bolus, and follow that by a half normal saline with D5, and then also do some potassium replacement, because a lot of times the babies will have metabolic alkalosis due to all the vomiting. And then after the operation, they encourage oral feedings as needed, with more emesis, and then just kind of gradually increase those feedings. Ruling out my differential diagnoses, I would rule out would be gastroesophageal reflux, and you can see there's no evidence of cough or wheezing, hiccuping, gagging, thumb sucking, which is typical of that. And the little spit up that these babies have is typically not projectile in nature. For that differential, clinical diagnosis is usually sufficient. You don't need to do any imaging, and treatment is usually not necessary, but they can do H2 blockers or PPIs. The other differentials I had were malrotation. I ruled that out because the baby is having normoactive bowel sounds, and it's more common in the first week to month of life. and this baby's having regular bowel movements. That is diagnosed with ultrasound and upper GI series, and treatment is surgical. And then finally, formula intolerance. I ruled that out based on the mother saying that she tried to change formula a week ago, and that did not improve symptoms. Pyloric stenosis would be confirmed with an ultrasound, and you would see thickening of the pylorus on ultrasound. That would also help you rule out the volvulus or malrotation. And then you would do CMP for electrolyte imbalances, and you could also check a gastric pH for metabolic alkalosis. Education for the parents would include that this baby needs to be hospitalized, that they need to have surgery, not to pursue feeding prior to operation, but then feeding could be encouraged after the surgery. And then I just have my references down there.
Good job. Did anyone else do the same case?
I did.
Okay. Do you have anything to add? Do you want to add anything?
I did find what I thought was interesting is in the treatment, which it said, let me find that. It's not usually done in the US or Europe or where surgery is available, but they can use atropine sulfate to do the resolution of the pyloric stenosis without surgery. And they just give atropine in 8 divided doses IV and then increase until the cessation of vomiting. And then it's given oral, but it did say that that's not used if surgery is available because that's the best option.
That's cool. I hadn't read that far. So when you have a child come in, are they always going to have the little olive?
Not always.
No, I
guess
think. Sorry, go ahead.
Go ahead.
Let's answer. You answer this, Trista.
Okay, so I did find that there's the classic triad of the pyloric stenosis, but it is only present in 14% of infants. And the classic triad is the projectile, non-bilious projectile vomiting, visible peristalsis, and then the palpable olive. But like I said, only in 14% of infants present with that triad.
So tell me, when you get this baby into your office, the parents bring it in, and tell me exactly what is your differential if you don't fill the olive and they bring the baby in. What other differential could you possibly have?
Which one? Go ahead, or you want me to?
Okay, Trista, you answer that one. Let me ask Kirsten.
Another one that they mentioned underneath that video was increased intracranial pressure. So I think that that's a possibility because of the projectile nature of the vomiting. So that was one that I would have considered had there not been the classic signs of the pyloric stenosis, or at least a classic sign of bowel being involved.
Okay. So anybody else have another differential?
I guess I did find the malrotation, the volvulus. I saw that she had that listed too. But the malrotation, it said, is usually diagnosed much earlier. And then the volvulus presents with an acute abdomen, which he didn't seem in distress or anything like that.
So hard. Okay. So we've ruled that out. Okay. Doesn't appear to have increased intracranial pressure. We don't have any bulging eyes, anything like that. We've ruled that out. What about anything else with the gut could cause projectile vomiting?
A bowel obstruction?
Could be, but you've got peristalsis and they're in all the quadrants, so maybe not. You'd probably have a hard, tight belly. Okay, so what about GERD?
Yeah, you could have that. Typically, I think it said that would be accompanied by the baby being reluctant to feed. So that's kind of a difference between that and pyloric stenosis. With the pyloric stenosis, often the baby is still eager to feed. So I don't know if that's something you could.
Here's the thing with the difference. A lot of parents will come in and say, this baby is projectile vomiting across the room, and the baby's over here laying, the baby's gaining weight, it doesn't look emaciated. Pyloric stenosis kids will look more emaciated, they'll be dehydrated, they typically have electrolyte imbalances because they're not getting any nutrition. GERD babies will still gain a little weight. They'll eat, and then they'll start getting that acid up, and they'll make faces. Sometimes they'll turn blue. And when they spit up, most of the time they don't projectile across the room. But if you've got them held up and you're burping them, you know, a lot of times they'll puke across your back. And so the parents will report that as projectile vomiting. So just be aware of the two differences between GERD and pyloric stenosis. So you're looking at pyloric stenosis with GERD, they won't have that. You won't be able to see those peristalsis because they are getting some nutrition. With pyloric stenosis, you'll be able to see peristalsis typically. They'll have hyperactive, their bowel sounds. They'll eat like they're starved to death, and then it's no sooner than they eat, it just projectiles, back up. With GERD, it's different. They have a little different. They look healthier. They don't look emaciated. Their heart rate's typically normal. Those kinds of things. They just have. So you'll see a lot of times they'll come in and report their projectile vomiting, and you'll have to rule out pyloric stenosis, of course, but most of the time it's typically GERD. Okay. All right, good job. So who wants to go next? Steven, you want to go? Oh, Stephanie, you want to go? Okay.
Yeah, sure. Let me see if I can make this work.
Okay.
Do you guys see that?
Yep. Can't hear it, Stephanie.
How about now?
No.
Maybe turn your volume up on the actual computer.
It's all the way up.
It's like your volume's not working at all. It's breaking in and out. Can you just send me the link? Can you copy the link and send it to me?
Yeah, I'll send it to you. I'll just kind of recap what it is.
Okay, that's fine. You can do it that way.
Okay, we have an 11-year-old female. She presents with complaints of abdominal pain that started about a week ago. She says the pain, let's kind of get this going. She said it's sharp and stabbing, a combination of both of those. She states it occurs in the lower abdomen, and then it goes around to her back. She denies any vomiting, but she does report some nausea. And she has had diarrhea twice. That's been watery. There's been no blood in the stool. There's no fever, denies fever. There's no current medications for her. The family does report that there is a history of digestive problems and ulcerative colitis within the family. What they don't present is, and additional information that we would want to know from this child is, has this ever occurred for her before, and the severity of her pain, although she doesn't appear to be in too much distress. And we also want to know if there's any pain on urination or any flank tenderness, any foul-smelling urine or anything like that. So on examination, her vital signs 98.7, 73.18, 115/74, so those are fine. She states that there is pain when we palpate, mostly to the lower abdomen. The bowel sounds are active in all quadrants. There's no rebound tenderness. There's no abdominal distension. There was a negative Rawhshing sign, which is when you palpate the left lower quadrant, and it's positive if there's an increased pain to the right lower quadrant. The obturator sign can also be elicited for this patient by internally rotating the flexed right thigh. A positive response is noted if there's a significant pain, and these are good if we're trying to rule out appendicitis. This patient's skin color is good. She doesn't appear pale. Her heart sounds are normal. And so when I look at differentials based on our presentation and exam, some differentials that I came up with was appendicitis, small bowel obstruction, because we don't want to miss these, and also constipation and UTI. So when we look at appendicitis, some significant positives could include the fact that this patient has abdominal tenderness on palpation and nausea. What helps us rule it out is that there's no rebound tenderness. The pain is not localized over the past 24 hours. And in fact, this child's pain is generalized throughout the abdomen. She has no fever. There's a negative Rausching sign. They show on the video, the physician has the child jump up and down. She does report some pain. However, there's not significant discomfort or guarding when she does that. So diagnostics that would help us rule appendicitis out, which we've talked about, would be the ultrasound and CBC. This patient did have an ultrasound on her video, which was negative for her. So when looking at the small bowel obstruction, the positive, significant positives would include abdominal pain, nausea, recent loose stools. However, we can rule this out, noting that there are active bowel sounds, there's no distension, there's no change in appetite for her or decreased oral intake. She doesn't have vomiting. She has no localized or severe abdominal pain. There's no rebound tenderness. There's no tachycardia, and her respirations are normal. So diagnostics that could help with small bowel obstruction would be an X-ray, CBC. If she had vomiting, we could do a CMP, but she doesn't have it. But we can rule out obstruction with our exam for this patient. And we always want to rule out a urinary tract infection when a patient presents with lower abdominal pain, especially that radiates to the back. And this child's pain has lasted about a week, which can be significant for a urinary tract infection for her. A urinalysis can be collected to rule this out, but we also noticed that she doesn't report any burning on urination or odor with her urine. So my diagnosis for this patient, which is what the video agreed with as well, is constipation. And after ruling out the severe complications, we see that this patient presents with generalized abdominal discomfort that's lasted for a week. She reports having loose stools twice, which is common with constipation. She has no fever. She's not vomiting. She has a family history of some abdominal and GI disease, which could be significant later if this keeps recurring. We could also include a rectal exam for this child, just to see if she has an impaction. So for diagnostics that we could include for constipation would be the abdominal X-ray, which she did have and was consistent with constipation. So for management, if an impaction is noted, we would provide medications at higher doses than a maintenance dose. We could do an enema, but for a child, I just kind of think that that's kind of invasive for them. So I went with magnesium citrate, which is dosed at 1 ounce per year of age. With a max dose of 10 ounces. So she would get 10 ounces daily for 2 days if she needed it. Also, we give Miralax at a maintenance dose, 17 grams or 1 capful, mixed in about 240 milliliters of water or juice. She can take it daily, or she can increase it every 2 to 3 days to achieve the mushy stools that she wants. Maybe 1 to 2 stools per day. And also let the family know that they can decrease the dose if liquid stools present, and she can take it every other day or a few days a week. And it doesn't have to be, a daily thing. We can have her wean off it as her stools become normal. Diet, education on diet. Normal fluid intake is recommended. There are no reports that show a difference in stool frequency when compared to an increase in water intake. So there's actually no need to increase her fluid intake. She should maintain a balanced diet to include whole grains, fruits, vegetables, and no fiber supplementation is required for her at this point either. Activity, increase her daily activity to about 30 minutes a day of active play. And she can follow up if there's no bowel movement in 2 to 3 days. If there's increased nausea, vomiting, severe worsening of abdominal pain, fever happens, or there's a change in appetite.
So Stephanie, did anybody else do the same case? Okay. Stephanie, did you do the urinalysis as well to check?
Yeah, you would do a urinalysis just to rule out urinary tract infection.
Yeah, even without symptoms, some kids will not have symptoms and complain of symptoms and still have a UTI. I have found, especially with the smaller ones, she's not, I mean, she would be able to tell you, but a lot of times the little ones won't be able to tell you what's wrong with them. But yeah, I would definitely went with constipation as well. It's really frequent. You see constipation. In the office, you can do just a regular abdominal series, which is a 3-view of the abdomen. You can tell if they've got, if they have constipation. When you are doing smaller children, you do 0.8 milligrams per kilogram of the Miralax. It works really well. I usually tell parents once they start to have loose stool, then to go to every other day to keep them on a maintenance dose. Does anybody have any questions about constipation? No? Sometimes when they have chronic constipation, they can also get UTIs because the stool backs up right there by the bladder, and it can cause a urinary tract infection too. So you have to watch those things if they get chronically constipated or they're coming in and they're getting frequent urinary tract infections. Checking for that as well. Questions? Yeah. Stephanie, you did a really good job with that. I like how you worked it up and you went through your differentials. Really good. Stephen, you want to go next?
Sure, I can go next.
Okay. Amber, can we hear you now? Did it work? Unmute there for a minute and say something. Can you say something, Amber?
Can you hear me?
Yes, we can. Yay. Okay, good. All right, you can mute now. Go ahead, Stephen.
Okay.
We can't hear it, Stephen. We don't have any sound.
I don't know why.
Have you got on earbuds?
No, and I mean, I listened to this 8 times before I even got on the Hangout thing, and it was.
Do you hear it?
No, it worked perfectly fine.
That's weird. Well, stop sharing and then try to share it again. Sometimes it maybe just didn't pick up the sound.
Let's see. Of course. All right, let's see here.
Now try it again.
No, it won't even play at all.
Are you okay? Maybe it's because. Can you send it to me?
Can I send it to you?
Yeah, send me the link.
Yeah. Let me see. Let me try it again.
Okay.
All right. Well, I guess it's not going to work. But I can go through the case, no problem with everybody.
Well, this is a good case.
You want them to hear it?
Yeah, if we can. Go ahead.
See if Amber wants to go, I guess, and I'll send this to you.
Okay. Amber, you want to go ahead and try yours?
hear me?
Hang on just a second. Can't hear you. I'm going to go ahead and screen share and play. You guys see mine?
Yeah.
All right, so we're here today with Allison's mom. This is Allison. She's not feeling very well right now. Mom, can you tell me what started today?
She had been fine all day, and then all of a sudden she would have bouts of it was kind of like she was throwing a temper tantrum.
Mm-hmm.
She could tell she was in a lot of pain and something wasn't right. And she had been having a lot of bowel movements throughout the day. So that's whenever she was in a lot of pain is when I decided to bring her in.
Was she constantly in pain, or did it come and go in kind of episodes?
It would come and go in episodes. She would be able to be soothed for like a few minutes, and then she would just start screaming again.
Okay. And how old is she now?
She is a year old.
Okay. And she looks like she likes sitting in that position. Is that the case?
Yes, she likes her legs to be kind of tucked up to her belly and just kind of laid over.
Has she been sick in any other way? Any runny nose or fever or anything like that?
She has not had a runny nose or a fever.
Any vomiting?
Yes, she threw up twice when we got to the hospital.
Okay. Any other medical problems for Allison?
She had MRSA, and they removed that surgically from her jaw as an abscess. Other than that, no.
Okay. Thank you, Mom.
Okay, did everybody hear that okay?
Mm-hmm.
Okay, Stephen, go ahead and now do your presentation.
Okay, so this is a 12-month-old female. Apparently was fine earlier in the day, had a sudden onset of abdominal pain, multiple stools throughout the day, and vomited twice since going to the hospital. She has not had any fever or runny nose, so kind of rule out any kind of viral causes of this, such as strep throat. A lot of times you can have vomiting from strep throat, or pneumonia can cause abdominal pain as well, but not really having any symptoms without fever. We don't really have any information about the characteristics of the emesis or the stools, which would be helpful in making a diagnosis of this. Vital signs, her temp was 99.4, heart rate of 130, respiratory rate of 36, blood pressure 102 on 60, and her oxygen saturation was 99%. So this is to me, the most concerning thing looking at this child is her lying on the bed in the manner that she is. Not typical for a 12-month-old to be lying like that when you go to assess them, for sure. So that's the number one most thing that stood out to me right off the bat. So kind of going through differentials, we always throw out constipation. Just the severity of the abdominal pain, I would probably go ahead and rule out constipation. Plus the fact of she's a little lethargic and not really consistent with constipation. Gastroenteritis, you can throw that in there. Again, without any fever, this is probably unlikely. She only vomited twice, and I'm not sure how much came out in the stool, so she could be a little lethargic from dehydration if she had gastroenteritis, but she was fine earlier in the day to all of a sudden not feeling good. I just don't think that's very likely. Another possible but unlikely, mostly based on her age, is the malrotation with volvulus. And I guess if you ran through some diagnostics and couldn't come up with an answer, you could search for that with the upper GI series if X-ray didn't show you what you were looking for. And that would be kind of on the back burner. Two most likely diagnosis, in my opinion, would be an intestinal obstruction and also intussusception. What I was saying about the characteristics of the stool, that would be helpful to know, because intussusception, they typically present with a what they call a current jelly stools, which is like mixture of mucus and blood. And then when you on the physical exam, a lot of times with the intussusception, you can feel a mass in the upper abdomen. Most times in the right upper quadrant, it feels kind of like a sausage, supposedly. So, you know, you want to check for that on your physical exam. And then, you know, a lot of the other signs point towards the intussusception, the sudden intermittent abdominal pain, so it's not continuous, coming and going, and then the lethargy. Things that I would do is I would get a CBC and CMP on this baby, do an abdominal X-ray to rule out obstruction, and probably an abdominal ultrasound as well to look for intussusception. Obviously, keep an NPO. You want to do pain control. I would do a urinalysis as well. You know, they could have potentially, I guess, a UTI, but I would say not likely. But generally, with kids, we always try and throw that in there just to make sure. Then obviously, based on your ultrasound and X-ray results, probably a surgery consult. If it's intussusception, this can be fixed with a lot of times what they do enema, an air or a barium enema. They prefer the air enema versus the barium. They can do either. And then admission to the hospital for observation if that's resolved. If not, then a lot of times you have to get surgery. So.
Okay. Good job. I'm going to go ahead and screen share and play Stephanie's video real quick that we didn't get to see. It'll just take a second.
So what brings you in today?
Abdominal pain.
When did that start?
About a week ago.
Where does it hurt?
From here over and it goes to the back.
Have you had any vomiting? Have you had any diarrhea? You have? How many times?
Twice.
Has there been any blood in it? Has it been watery? Have you had any fever? No. Anyone in your family have any belly problems?
No.
What do you have?
I have nothing that's been technically diagnosed, but I've had lots of abdominal and calcified glands, almost IBS, but never been diagnosed with IBS. I'm not quite sure yet. My sister lost all of her colon when she was UC.
Ulcerative. All right, sweetie, can you tell me what kind of pain is it? Is it sharp or stabbing?
It's a mixture.
A mixture? I'm going to go ahead and fill your belly, okay, sweetie? Does it hurt over here? Does it hurt over here? No? How about over here? Up here? When I press on this side, does it hurt on this side? It does? When I press in here, does it hurt more when I press or when I let go? When I press? Can I go ahead and bend your knee? Does that hurt? It does hurt. Can you go ahead and stand up for me? Can you go ahead and jump up and down? Does that hurt? And you guys went to the hospital a couple days ago? So about 3 days ago? What did they do there?
Blood work, urine, and CT.
Great. Thank you, sweetie.
Okay. So, did you guys see the difference in Stephen's video and Stephanie's video, the difference in the way the patient presented? That was why I wanted to show you both of those together. The baby was curled up, legs pulled up, not moving. This kid is toxic appearing. The little girl in Stephanie's video, when they put her legs up, when the provider put the legs up, she said it hurt. But then when she told her to get out of the bed, she just jerked her legs up the same way and flipped around and moved. And, you know, so I'm not saying she wasn't in pain, but I'm saying she wasn't as toxic appearing. And that's some things that you want to be cued into. She wasn't as toxic as Stephen's child, okay? So we want to look at those things when we're ruling out the bad things, you know, with Stephanie's child, okay? So that's why she could move on to the diagnosis of constipation. Now, if I had a child that had a CT scan 3 days ago, like she had, I would call and get that information to see what that CT scan showed. Okay, and sometimes you'll see that they've been in the emergency room and they're following up with you to see what you're going to do about it. And so, just like she said, it's constipation. We're going to put the child on something, and then you're going to monitor to see how she's doing. Okay. Does anybody have any questions on the difference in the children and abdominal pain, the different things that you do? Intussusception is definitely an emergency if you have a kid come in with the blood current stools and the sausage-like, the severe abdominal pain, that definitely needs to be worked up. Call either a pediatric surgeon. If you don't have one that you can call, then you would send them definitely through the emergency department. Okay. All right. So, Amber, have you got your video? What's the video? What's the number of the video?
I actually went ahead and emailed it to you. It's 3:15.
Okay, let me go ahead and pull it up, and I'm going to go ahead and screen share and show it, okay? We're having too much technical problems today for some reason. All right. Okay, I'll show this real quick, and then you can do the other stuff.
Okay.
All right. Here we go.
All right. How long have you been sick?
Since Saturday.
Since Saturday? And what happened first on Saturday?
When I started to have a fever.
You started to have a fever, and then what happened?
My belly started to hurt.
Mm-hmm. Anything else?
And after that, I started throwing up.
Started throwing up. So that was almost 5 days ago. You've not been feeling well. Is that right? Okay. And you said your belly started hurting? Where? Can you point and show me where it hurt?
Right here.
Right there? Okay. Did it start out hurting right there, or did it start out hurting somewhere else?
It started hurting right here.
Right over your belly button? And then what happened?
It went over here.
It moved over there. Okay.
All right. Now, you're ready.
Okay. So we have is a little 8-year-old boy brought in by his parents with complaints of abdominal pain and vomiting for 5 days. The pain started right at his umbilicus, moved to the right lower quadrant. There were no other health issues listed, but they did say he had a remote history of constipation. Information. He has no known allergies. He takes no medicines, no prior hospitalizations or surgeries for him, neither of which are sick. symptoms overall was unremarkable except for the GI complaints. His vital signs were actually all normal, 98.9, so he's afebrile now. 36, respirations 24, 17/75. Height and weight. The distress he's really in, as you can just tell, he's been sick for several days. Differential diagnoses are actually the exact same as what we talked about before when it came to the abdominal pain. My number one was appendicitis, my second was mesenteric adenitis, and then third was constipation. Honestly, for this little boy, he would really need a good workup to even rule out constipation because he does have a history of constipation. It's a fever that kind of makes it a little more doubtful, but you still can't completely rule it out. Mesenteric adenitis, as we said before, you can be sick up to 3 weeks with it. You can have a low-grade fever. You can have all the symptoms. But appendicitis is still the number one top diagnosis that you'd want to look for and rule out first because it's the most. So, of course, he's pediatric. Ultrasound, like we said, would be the very first choice. Do blood work, a CBC, see if his white blood cell count is elevated, which with the fever already being on and off, you would hope if it was something like that, it would be it, but it may not. If you were to send him home, if everything were to come back okay, you would still want to make sure to tell the parents appendicitis and you were able to rule out constipation for him. They wouldn't want to do any laxatives or enemas, apply heat to the abdomen, anything like that until you have appendicitis completely ruled out. Referral for surgery, if it was emergent, said before. If not, you contact a surgeon, see what the recommendation is.
Okay. Good job. So, did you guys see the difference in him? How toxic looking he looked? He looked really ill appearing. And he looked more like someone who had a toxic issue. Does anybody have any questions for Amber?